When a patient wakes up from a colonoscopy, the physical procedure is over, but for the physician, the real challenge is just beginning. The pathology report on a single colonic mass is a complex dataset that dictates both cancer risk and clinical management. This flowchart divides all colonic polyps into two categories. On the green, non-neoplastic side, are hyperplastic, inflammatory, and Hamartomatous polyps, carrying negligible malignancy risk. The red, neoplastic side represents adenomas, the definitive premalignant lesions of the colon. Correctly identifying an adenoma is the primary trigger for the physician. It initiates the entire downstream colorectal cancer surveillance protocol. Adenomas are categorized into three architectural subtypes: tubular, Tubulovillous, and Villous. To sort them by risk, remember the mnemonic, Villous is the villain. A villous adenoma has long, finger-like projections that create a massively expanded surface area for dysplastic cells to multiply, resulting in a 3 times higher malignant potential than a standard tubular adenoma. There is a deceptive exception to standard adenoma classification, the Sessile Serrated Polyp. Sessile Serrated Polyps bypass the standard APC gene mutation entirely. Driven by BRAF and TRAS mutations, they are notoriously flat, difficult to visualize, and preferentially located in the right colon. This matrix defines the clinical criteria flagging an adenoma as high risk: size 10 mm or larger, villous architecture, high-grade dysplasia, or 3 or more polyps. Specifically, greater than or equal to 10 mm or villous features significantly escalate the threat level. Any adenoma meeting one of these high-risk criteria alters the patient's prognosis and accelerates the required surveillance timeline. While sporadic polyps develop from acquired mutations, inherited syndromes involve germline mutations present in every cell. Familial adenomatous polyposis, or FAP, is caused by a mutation in the APC tumor suppressor gene on chromosome 5q21. Without a functional APC gene to regulate cell growth, patients develop thousands of colonic polyps by early adulthood. Because FAP carries a 100% lifetime risk of colorectal cancer, prophylactic proctocolectomy is the standard of care. This anatomical map shows how FAP presents with extra-intestinal features. Gardner syndrome, remember Gardner grows things outside, pairs FAP with osteomas, desmoid tumors, or supernumerary teeth. Turcot syndrome, remember Turcot wears a turban, pairs colonic polyposis with malignant brain tumors. In a clinical vignette, the presence of bone growths or a cranial mass differentiates these specific FAP variants from isolated polyposis. Lynch syndrome, or hereditary non-polyposis colorectal cancer, is a separate dominant genetic pathway. It is driven not by the APC gene, but by mutations in mismatch repair genes, such as MSH2 and MLH1. When mismatch repair proteins fail to correct errors during replication, the cell develops a hypermutable state known as microsatellite instability. Physicians use the 3-2-1 Amsterdam criteria: 3 relatives with colon or endometrial cancer across 2 generations, with 1 diagnosed before 50. This global DNA repair failure extends risk beyond the colon, driving high rates of endometrial and ovarian cancers. For these patients, a comprehensive surveillance net must account for more than just the gastrointestinal tract. The final category includes the Hamartomatous syndromes. While hamartomas are technically non-neoplastic, these syndromes still significantly elevate the risk of gastrointestinal malignancy. Peutz-Jeghers syndrome is driven by a mutation in the STK11 gene. The pathognomic finding is mucocutaneous pigmentation. Hyperpigmented macules appear on the lips and buccal mucosa, cemented by the mnemonic, Peutz equals pigment. Juvenile polyposis, caused by SMAD4 or BMPR1A mutations, typically presents as isolated gastrointestinal bleeding in a pediatric patient with multiple hamartomas. Identifying lip pigmentation or a pediatric presentation of bleeding allows a clinician to bypass standard adenoma protocols and move directly toward these outlier syndromes. The ultimate clinical application of this data is determining the exact post-polypectomy follow-up interval for a patient. This decision tree illustrates how pathology findings dictate the timing of the next colonoscopy. A low-risk colon, one with no polyps or just 1 to 2 small tubular adenomas, permits a return interval of 7 to 10 years. The high-risk pathway shrinks the interval to 3 years. This is triggered by 3 to 10 adenomas, large sessile serrated polyps, or any single high-risk feature, like villous architecture. The extreme risk pathway is triggered when more than 10 adenomas are discovered simultaneously. Finding more than 10 adenomas halts standard guidelines and necessitates an immediate evaluation for an inherited syndrome like FAP. To lock in the core histology, Villous is the villain, mandating a 3-year high-risk follow-up. For FAP variants, Gardner syndrome involves bones and teeth, while Turcot syndrome is marked by brain tumors. For the outliers, Peutz-Jeghers presents with lip pigment, and Lynch syndrome requires screening for both colon and endometrial cancers. Mastering this matrix translates raw pathology findings into the precise diagnoses and surveillance intervals required for clinical practice and board examinations.